welcome to Module 3. Today we're going to be talking about the electronic health record. The important things about this module, the objectives we're trying to accomplish, are to differentiate between the different records, EHR versus EMR versus PHR, identify the attributes and functions of the HR, and we're going to kind of look at the 7 levels of HIMSS integration or implementation. Describe the systems and network requirements to support effective EHR implementation. Most of those are going to be the computer systems that you've already learned about in the previous modules. And explain how the use of an EHR system can affect patient care, safety, efficiency of care practices, and outcomes. But first, an electronic medical record. A lot of times EMR and EHR are used or interchangeably with each other. And the reason is because people really don't understand the differences. But the electronic medical record primarily is a computerized patient chart that is within an organization, that a defined set of caregivers can see this record of patient information. Yes, you can put data in about the patient. Yes, you can extrapolate information from the data that you put in, but it's primarily contained within a facility or an organization. The health record, and this is really part of the reason with 2009 why it was such a big deal to implement these standards, was the fact that we could now take that electronic health record across organizations. So not just within the hospital or even within the organization, but of course between organizations. That allowed for a lot better continuity of care going from admission or outpatient clinic into the hospital through testing phases and then back out to an outpatient clinic or to subsequent treatments after that. We also have the patient health record, the PHR, and this is the information that a patient actually has control of. A lot of times, and one of the objectives of meaningful use was that the effective use of PHRs. So your physician would have some sort of a portal that you could log into with a username and password and actually see some of your information. The challenge was that although the facilities and the organizations and the doctors would implement this technology to allow for PHR, actually getting people to use it and to log in to see their test results, to see their lab results, to see medications or history about their visit was very challenging. So even though patients now, and especially we'll talk about this a little bit later on in the course with HIPAA, now had the ability to have access to their electronic medical records and to their healthcare, they still don't do it, and trying to figure out why. They're very active perhaps in checking out their bank balance, but actually logging into their physician to check out their lab results, a whole different challenge. And then how do you measure a organization or a physician based upon the behavior of someone who they really don't have any control over? It's bad enough sometimes just to get patients to be compliant taking their medications or showing up for doctor appointments, much less making them log into a PHR, which is essentially theirs, and there's no reason not to do that. Then there's the computerized patient record. It's an electronic record specifically focused on just one patient and that patient's care. That is really the digitized paper chart. And what we went from paper chart to getting the CPR really did help, especially with handwriting and things like that. But that was really the precursor to going to an electronic medical record. So depending upon the complexity of the system, this computerized patient record might be a way to put data in about a patient, but actually pulling information out or having it integrate or interface with other systems, much less across organizations, is almost non-existent. So those are kind of the different types of medical records or charts that you will see or hear talked about. As far as the attributes and functions of the EHR, I really want to focus on the 7 stages of EHR implementation and adoption that have been identified. Now, this is a HIMSS-driven Health Information Management System Society, and the stages start from 0 all the way up to a level 7. But at 0, there's almost no computerization that's been installed. Back in the early 70s is really when we started to see computerized systems being adopted in healthcare, and typically it started with the ancillaries. And when I'm talking about ancillaries, we're talking about rad, radiology, as well as laboratory, and then also pharmacy. And by the way, we're talking about 0. That's nothing is installed. So stage 1 is when all 3 ancillaries are installed. I would be hard pressed to think that there are any organizations out there that you might encounter that would be at stage 1, but it certainly is a possibility. Most have at least gotten to at least a stage 2, where there's a clinical data repository, a centralized database, and there is some rudimentary, at least, clinical decision support in the aspects of alerts or recommendations based upon lab tests or radiology results, or drug interactions with drug-drug or drug condition interactions. And to have that, there has to be some sort of a controlled medical vocabulary. And that's very important for that interfacing and integration. HL7 is something that you may hear about as kind of a language, pipes and carrots. It's a lot of programming that allows for the interfacing of 2 disparate systems. But again, stage 2, then we get into stage 3.